Hi, my name is Mary Helen. I'm a nurse practitioner with Stedman Hawkins Clinic. I'm going to give you some information today about preparing for your upcoming hip or knee replacement surgery. Again, we're glad you have chosen Stedman Hawkins and Patewood as your center of orthopedic surgery. We are recognized by the Joint Commission as having our advanced total hip and knee replacement certification. We are one of only 3 hospitals in the state and one of less than 100 hospitals in the nation to have this advanced certification. We are recognized by the American Academy of Orthopedic Surgeons, and everything that we do is based on research and evidence-based practice. These are just a few of the awards that we have received in the last several years, some as recently as December. And these are all of our hip and knee replacement surgeons. Today we're going to discuss preparing for surgery, day of surgery, possible complications, leaving the hospital, home expectations, concerns you might have, and driving. These are typical post-op x-rays of what your new knee or new hip might look like after surgery. You see in the top x-ray is a picture of a partial knee replacement, meaning probably only part of your knee is worn out and needed to be replaced. On the bottom left would be an x-ray of your knee after surgery if you had a total knee replacement. And then on the right is an x-ray of a hip replacement. You see the ball and socket joint and the rod that goes down into your femur. Now these implants are made out of titanium, oxynium, cobalt chrome, or ceramic. They should last you for a good 20 years or more. The surgeon makes a decision on which implant to use based on your height, your weight, your activity level, and lots of other factors go into play. It's actually a little bit more complex than that, but they have a very good idea of what type of implant they want to use for you going into surgery. So without being too graphic, just know that the surgeon will remove the worn out bone. He will put a model piece in because he also wants to make sure that it is the correct size for you as well as the right fit. They may have to go up a size or down a size, but once they get it exactly as they want it, then they'll put the permanent implant in. And again, that should last you for a good long time. With any surgery, we want to prevent infection. So I'm going to tell you some things that we do here at the hospital to prevent infection, and there are some things that you all can do to prevent infection. The easiest and probably the most important thing that you can do is good hand washing. So make sure you're washing your hands for a good 20 seconds or more each time, and do that quite frequently, even after you return back to your home. Also, ladies, if you're having surgery and you shave your legs, please don't shave your legs for at least 3 days prior to surgery. That can lead to nicks and cuts and other portals of infection. As far as showering, your nurses and pre-assessment will review with you the appropriate way to shower with the Dial, Hibiclens, and the CHG wipes. Make sure you do follow those instructions provided for you. Just reminding you to go ahead and pick up your Gold Bar Dial soap. If you can't find Dial, you may also use Lever or Safeguard. Also, you want to avoid any activities that might damage the skin of your surgical extremity for 1 to 2 weeks prior to surgery. So if you're working in the yard or using tools, be mindful of protecting the skin of your operative leg. Also, don't let any pets jump up on you and scratch you. We've had to cancel surgery because of people who have come in with rashes or cuts that did not heal. This is a copy of the skin prep tip sheet that will be provided for you from your nurses. They will date that for you and make sure that you understand how to shower properly. Also, we want to focus on good nutrition in the weeks before surgery. So if you have a choice, make sure you choose what we call whole foods, which are foods in their more natural state, such as fresh or frozen fruits and vegetables, lean dairy products, and or lean meats and low-fat dairy products would also be more beneficial for you to eat. So you see some good suggestions there. Also, we want to focus on what you eat the night before surgery. So I would not have a heavy meal, but if you'll eat a lighter dinner anytime between 4 and 8 p.m. That usually covers most everyone's dinner time. We've given you some suggestions of healthy meals that you may fix the night before surgery. Also want for you to think about drinking your Inshore, which I'll talk about next, anytime between 8 and midnight. Now, this is Inshore pre-surgery clear carbohydrate drink. This will be available for you to purchase in pre-assessment. Now, these instructions are are just general instructions for those of you who are not diabetic and you've never had gastric bypass surgery of any sort. We will use the Inshore for you to help reduce nausea and vomiting and help reduce your insulin resistance. So this is not your normal Inshore that you would have at the grocery store, but it is specially prepared for surgery patients just like yourselves. So remember, follow these specific instructions that the nurses give you. But in general, you want to drink your 2 bottles of Inshore the night before surgery, anytime between 8 and midnight, and preferably drink them back to back. They are better served cold, so put them in the refrigerator a couple of days before surgery, and they are strawberry flavored, tastes kind of like strawberry jello. Now you'll want to drink your 3rd and final bottle of Inshore up to 3 hours before your arrival time here to the hospital. Don't drink it on the drive in. You want to give your blood sugar time to come back down, so that arrival time is going to be really important. For example, if we tell you to be here at 10 a.m., you'll want to drink your Inshore before 7 a.m. And if you have to be here super early in the morning, like 5:30 or 6 a.m., then I would suggest setting your alarm for 2:30 or 3 a.m., getting up, drinking your Inshore, and then you can go back to sleep for a little bit. So don't worry, we will give you plenty of time to nap after you get out of surgery, and we also have plenty of coffee for you available after surgery. And as a reminder, if you're a type 2 diabetic but you're not on insulin, drink only that 1 bottle of Inshore the morning of surgery. Now, you all know your surgery date, of course, but some of you may not know your arrival time yet. So we will call you 3 to 5 days prior to your surgery date with an arrival time. So again, that's important for obvious reasons, as well as to remind you as to when you can drink your Inshore. Also, I want you to pick up some extra strength Tylenol. We recommend that you take 2 of those the night before surgery. So we do recommend the extra strength Tylenol at 500 milligrams as opposed to the arthritis strength. That will put you too far above your recommended daily limit, which is 3,000 milligrams in a 24-hour period. So just take 2 the night before. We'll give you Tylenol once you get here to the hospital and continue that regimen while you're here in the hospital and then even after you are discharged. Taking Tylenol on a consistent basis does help build a baseline of pain control in your system. And we can always add something else to that. And I'll talk more about pain relief later on. If you have a fever, any signs of illness, or any opening in your skin, please call our pre-op nurse at that number there prior to coming in on the day of surgery, and we will give you further instructions. Also, if you have sleep apnea and wear a CPAP or a BiPAP machine, please bring your mask and your machine in on the day of surgery. We would greatly appreciate that. We do have distilled water for you, so you don't have to bring that in. We will provide that for you. For the day of surgery, we'll have you check in at the front desk and have you swing by the business office for registration. We'll make sure that you have all of your paperwork signed, and we will escort you and your family member up to the surgery waiting area. Please consult your nurses in pre-assessment, and they will let you know what the current visitation policy is for our hospital. When they are ready for you in pre-op, they will bring you into pre-op, have you change into a hospital gown, check your vital signs, give you medications. We'll start an IV, and we'll do further surgical skin prep, usually with the CHG wipes on your hip or your knee. You'll be met by a member of the operating room team, like the CRNA or the anesthesiologist. They'll discuss either an epidural or spinal for you, or using general anesthesia. The surgeon will also come by, and he's going to verify which leg he's going to operate on. He will initial that leg and answer any final questions that you might have. And then the very last thing you'll do before you go to the operating room is to get up and use the bathroom and empty your bladder. That's going to be important for something else I'll talk about in just a moment. Once you get into the operating room, we will observe sterile technique, of course, and try to limit the traffic coming in and out of the operating room. Our surgeons will perform a surgical timeout. What that means is right before they make the initial cut into your hip or your knee, they'll say, hey, I've got Jane Doe here. She's having her left hip replaced and she's allergic to amoxicillin, for example. So he will share with the operating room staff anything that is pertinent for them to know. That way everyone is on the same page. We'll also give you your first dose of IV antibiotics at this point. If you do spend the night in the hospital, then you will receive 2 other doses of IV antibiotics. Now, a few of our surgeons do give oral antibiotics when you are discharged, but that is patient specific and surgeon specific. And you will usually be in surgery for about 1 to 2 hours. While you're in surgery, we ask that a care partner stay in the facility during your surgery. Our nursing staff will keep them updated throughout your surgery case. And the surgeons will usually come by and update you if you're in the room or the family, after surgery is done, either in between their cases or at the end of the day. Now, these are possible complications. These are uncommon. We can usually fix most everything except for the last thing on the list, but we don't do that here, so I won't talk about that. But I do want to mention some of these other things, as I feel an educated audience is very beneficial. So infection is not something that you want. We try very hard to keep our infection rates very low. One thing that we do is we have a hand sanitizer dispenser in your room on the 2nd floor. So we encourage everyone to use the hand sanitizer as they are coming in and out of your room. That includes the surgeons, the therapists, the nurses, and also remind your family to do that as well. As far as injury to vessels or nerves, when the surgeons are making the initial incision into your hip or your knee, they may cut through little microscopic nerves that they can't see. If that is the case, then you may be numb on the incision line or maybe to the side of your knee if you're a knee patient for weeks to maybe even a couple of months until those nerves do regenerate. Something else that may occur is something called foot drop. What that means is you can point your toe, but you are unable to flex your foot temporarily. Everyone is usually still able to get up and walk around even if you do have foot drop. It usually does resolve on its own overnight or in a day or two, and it's nothing to worry about. As far as wound healing problems, we don't have very many of those. We have a special bandage that we use called a Mepilex. It's a white foamy bandage about 1 foot long. It has silver in the middle, and the silver has antimicrobial properties. That Mepilex will stay on your hip or your knee after it is placed in the operating room for 14 days. It will be changed by your home health provider. Usually if you're a knee patient, you'll probably have staples in your knee, so they'll remove the staples in 14 days and put little steri strips or paper tape across your incision. For hip patients, you usually will have internal sutures and skin glue used to close your incision, so they'll just take the bandage off in 14 days and put the steri strips or paper tape on your incision. So that's really all you need to know about that. You really don't have to do anything with that dressing other than cover it when you shower. So I would suggest getting saran wrap or Glad Press and Seal if you're a hip patient. It is sticky on one side. You can tear a piece of that off and place that over your bandage, and it is very helpful to keep that covered and dry when you are in the shower. You would just peel that off after you get out of the shower, keeping your dressing in place, and then pat that dressing dry. Sometimes with knee surgery, you're a little bit stiff when you first get up and start walking. That's pretty normal. So that will get better over time after when you take the first few steps, that will get better. Next is dislocation of the hips. So you will meet with an occupational therapist while you're here at the hospital who will give you instructions on what to do or what not to do to prevent hip dislocation. You'll want to follow those hip precautions for 4 to 6 weeks to be on the safe side and make sure that you don't dislocate your hip. The main thing is you don't want to bend forward and break a 90-degree angle by reaching down, for example, and picking something up. So our physical therapist will review those hip precautions with you as well and make sure that you know what to do. Next is DVT, that stands for deep vein thrombosis. That's a fancy term for a blood clot. If that breaks off and travels to your lungs, it can become a PE or a pulmonary embolus. You don't want either one of those, and I'll tell you things we do to prevent those later on. Next is a fracture. That refers to our hip patients primarily. Remember in the x-ray, I showed you the picture of the rod that goes down into your femur. Sometimes when the surgeons are placing that rod, they may have a small fracture that occurs. If that does happen, they recognize that and they can stabilize that during surgery. So you'll still be able to put partial weight on your leg after surgery, and it usually heals quite nicely. As far as medical conditions, if you have any medical conditions like diabetes or high blood pressure, for example, sometimes the stress of surgery can cause those numbers to fluctuate a little bit. If we are concerned about anything, we can consult our hospitalist, which is an internal medicine physician. It's here on staff 24/7. So they are great resources for us and they help us take care of you. And lastly is persistent pain. If you do have pain after surgery, most people say that it is less than the pain that you're probably having right now. And I'll talk more about pain control later on. Next, you'll move out into the PACU or the recovery room. There we will monitor your vital signs. We'll give you cold therapy and use SCDs. We'll give you something to keep you comfortable and something for nausea. And you're usually going to be in the recovery room for about 1 hour or a little longer. Now, some of the things that I just mentioned include the SCDs. That stands for sequential compression devices. Those are sleeves that go in your lower leg and they alternate and they squeeze and they keep the blood flowing. That's a great way to prevent blood clots. You'll have those on when you first come out of the recovery room, and we will leave those on until you do get up with physical therapy. If you do spend the night in the hospital, we will reapply those at bedtime. Next, skipping down to the bottom is the incentive spirometer. That's a good little machine. You take a good deep breath in with that, help expand your lungs and prevent pneumonia. So if you're prone to upper respiratory issues, then make sure you do take that little device home with you, and our nurses will review with you how to use that. And lastly are our cold therapy wraps. So you see them for the hip and the knee. Everyone will get a wrap and 4 of the blue gel pads to use. So the benefit of these is you can get up and walk around with these. There's no cords, no tubing, no heavy ice to lug around. So these wraps will stay cold for about 4 hours or so. If your family is here with you in the hospital, they can help you change those out, and our nursing staff will do that as well. So you'll use 2 of the gel packs at one time, and then you'll have 2 extra. There are freezers for those gel packs in your room on second floor. So again, you'll have 2 gel packs in the freezer and you can rotate those out as needed. I do encourage you to use these gel packs and these wraps as much as possible while you're here in the hospital. That's going to help prevent swelling and pain. After you get back home, if you find them to be helpful for you, go ahead and use those as much as you would like. At a minimum, I would use the wraps for about 15 or 20 minutes or so, about 4 times a day, especially after you do your exercises. So those are great little wraps that we have now, and we really like those. They're very safe for you and user-friendly. Next is blood clot prevention. They are uncommon, but you definitely don't want one. So the best thing that we can do to prevent you from getting blood clots is to get you up and get you walking the day of surgery. So I'll mention more about physical therapy in a moment. Something else you may also do is ankle pumps or our ankle pumps. So you can point your toe and flex your foot, do that repeatedly. That's ankle pumps. And those are going to be very helpful to prevent blood clots. So make sure you're doing that if you're riding in the car for a long time, if you're flying somewhere. That's going to be helpful to prevent blood clots. I mentioned the SCDs or the compression devices that you'll be wearing. And then you may have been given a medication to prevent blood clots by another practitioner, such as Coumadin, Xarelto, Eliquis, or Plavix. Now, we've instructed you to stop those blood thinners before surgery. We will usually restart those blood thinners the day after surgery. Now, for everyone else who is not on one of those special blood thinners, then we want you to get aspirin. It's going to be an 81 milligram coated aspirin, also known as a baby aspirin, and you'll take 1 in the morning and 1 in the evening for 1 month following surgery. So go ahead and pick that up as well. So you'll have that. You don't have to start that before surgery, but again, you will start the baby aspirin and take one twice a day for 1 month following surgery. As far as blood conservation, of course, everyone loses a little bit of blood with surgery, so we try to limit that with the various surgery techniques and medications that we use. When you come in for pre-assessment, we will check your hemoglobin and make sure that you are at optimal levels going into surgery. Very rarely do we have to give blood transfusions anymore. Next, you'll move out to our short stay surgery unit. There you'll be in a private room. We will do something called bedside shift report. What that means is the recovery room nurse will bring you out to your room on the second floor. They will give your nurse a report, just basically telling them who you are, what you had done, maybe what medications they gave you. We will repeat that report at shift change, which is 7 o'clock at night and 7 a.m. in the morning. We'll also give you a patient education booklet, and we will do something called bladder management education. So because most of you will have received an epidural, you may be a little bit numb from the epidural, and you may not be able to tell that you have to go to the restroom. So we will scan your bladder with an ultrasound machine. We want to make sure that your bladder is not overly full. So if it has more than 300 cc's of urine in your bladder, we'll put a catheter in, drain your bladder, and then take it right back out. So it's kind of rare that we have to do this out on the short stay surgery unit as much anymore, but I just want to give you fair notice in case we do. We want to prevent any bladder distension, which would lead to problems for you later on down the road. We use the scale below as a guide to help us manage your comfort. It's a 0 to 10 scale, with 0 being no pain, 10 being the worst possible pain. Our goal is to keep you comfortable, usually on a 0 to 4 on that scale, but notice I did not say pain-free. But a lot of our patients are very comfortable with the scheduled medications that we give them to keep them on that 0 to 4 range. If you find your pain level increasing to a 6, 7, or 8, please contact your nurse and let them know, and they can give you some additional medications, such as narcotics. Now, the narcotics do cause constipation, nausea and vomiting, dizziness, or lightheadedness in some cases. So our nurses try very hard to find something that works well for you, but does not cause the side effects for you. So again, I'd rather you be awake and alert and talking to me in a 3 or 4 on that pain scale than to think that you are going to be a -10 on the pain scale and be over sedated, and you may have other problems then. So we try to find that happy medium. There are several things that we do to keep you comfortable. I've mentioned the spinal or the epidural anesthetic that we use for most people. Our anesthesiologists are very proficient at doing the spinals, so they do hundreds of these a week. So that's really the safest way to go, and most of you will get a spinal. You'll be when you get into the operating room, we'll have you get on the side of the bed, sit on the side of the bed and lean forward a little bit, and that's when they start the epidural. But they'll also give you some medication, so most patients say that they don't remember anything past sitting on the side of the bed in the operating room. Then we'll assist you to lay down on the operating room table, and they will begin prepping you for surgery. You'll also get a local anesthetic mixture injected into your joint during surgery. That's a cocktail of 4 different medications that will be given to you to help with pain control. That usually will start working by the time you are out on the nursing unit, and it will last for 48 to 72 hours. If you're a knee patient, we'll give you an adductor canal block, which is another injection that you'll get in surgery to help interrupt the nerve pathway and provide pain relief. All of these things overlap, as well as we'll give you anti-inflammatory medications if you can take those, Tylenol or acetaminophen as scheduled, as I mentioned before. We want you to use your cold therapy wraps as much as possible and keep your legs elevated. If you're not lying in the bed, you're going to be sitting in the recliner, so make sure you keep your legs elevated. The oral narcotics I've mentioned that are more preferable as opposed to the IV meds. And then I want you to pay attention to these apps for relaxation and sounds to reduce discomfort and anxiety. So you will be given this paper in your handouts of information. These are apps for relaxation and meditation that our surgeons want you to look at and see what works for you. So a lot of these apps that you can download on your tablet or your phone have relaxation exercises, meditation, calming music, deep breathing exercises. All these things are going to be beneficial to help you naturally calm yourself and dispel the anxiety that you might have by doing some of these activities. So these really do work. Research is behind that. So make sure you kind of play around with these and find something that works for you to help you relax a little bit and reduce your discomfort and anxiety before surgery, so you can use these to help you after surgery as well. Some people prefer to look up YouTube videos, so you may do that, look up relaxation, or you may try to find singing bowls on your browser as well. So those are beneficial also. And you're at risk for falling when you're here. So you're connected to your IV, to your SCD tubing, and we've given you lots of medication. So if you need to get up for any reason, please don't try to do that on your own. Please call us. You'll have a call light located on your bed, and call us and we'll help you get up to the restroom or into the chair. Now, as far as physical therapy, our physical therapist will usually get you up the day of surgery. If by chance you come out later in the evening or in the late afternoon and you're still numb for a while, then our nursing staff will get you up that night and you'll see physical therapy the next day. But when you do work with physical therapy, they'll assist you with some exercises to do. They'll review your surgery precautions, teach you how to get in and out of bed, to stand and walk using your walker, and teach you with stair training, how to go up and down steps before you go home. So all those things are designed to help you leave here safely and get around your home adequately. So we also want you to make sure that you bring comfortable shoes and clothes. If you're a knee patient, you want to make sure that you can roll your pants legs up above your knee. So anything comfortable to wear would be fine. Try to bring rubber-soled slippers that maybe lace up or Velcro. Just remember though, if you're a hip patient and you have tennis shoes that tie, you won't be able to lean over and tie those. So you'll have to have assistance with that. But just anything loose and comfortable would be beneficial. And usually our physical therapist will see you again the day of surgery. Now, as far as discharge planning, it begins before you even get to the hospital. So you will be contacted by a nurse case manager or social worker to talk to you about home health. Home health is the broad term for a home health physical therapist and perhaps a nurse as well. So everyone will definitely see a physical therapist, and you may or may not have a nurse come out to see you also. We'll also arrange to get you some equipment like what is pictured here if you are not borrowing equipment from a friend. So we do recommend a walker like the one pictured here with the 2 fixed front wheels. We don't like the walkers with the seats or the 4 swiveled wheels. Those can get away from you and they are not safe. So only borrow a walker that looks like the one there if you are going to. Now, if you don't have access to a walker, then don't worry. We will order that for you. It will be delivered by our case managers to you in your hospital room before you can go home. Now, if you're a hip patient, then you will also get a bedside commode like the one pictured here. You can take the pan out of the bottom of the bedside commode and put this over your existing commode. That way it will allow you to observe those hip precautions and not sit down too low, but you've got the elevation and the handrails to help you get up and down off the commode. Now there's a link for a walker video that you'll be given as well. Make sure that you watch that. That will show you the appropriate way to use your rolling walker while you're here at the hospital and after you go back home. Now, before I talk about the day after surgery, let me briefly mention what we call same-day surgery discharge. So if you and your surgeon have talked about you going home the same day, then that's great. There are certain parameters that have to be met in order for you to go home the same day. And also keep in mind that you may always change your mind. If you get here and decide you'd like to stay overnight, that is no problem. So those parameters that have to be met would be you have to do everything you need to with physical therapy to get home safely. Your pain needs to be under control with oral pain medicine, and you need to be able to empty your bladder with no problem. Also, your surgeon, of course, has to approve of you being ready to go home the same day, and you need to have your equipment on hand, as I just mentioned before. So we realize that is works well for some people. Usually we'll try to schedule you as a same-day discharge with an earlier surgery. Just so long those parameters are met that I've mentioned, then you can go home later that afternoon and sleep in your own bed that night. However, we realize that that may not be the best for everyone. So if you do stay overnight, then the day after surgery, we may change your dressing. That's not the main one that I talked about, but usually it's giving you a shorter ACE wrap that's on your leg if you're a knee patient. We may also check lab work and make sure that that is okay for you the day after surgery. You should be on oral pain medicine as opposed to IV pain medicine by the time you're ready to go home. And everyone has their own individualized physical therapy plan. So sometimes we're able to do everything for you in one therapy session, or it might take 2 or 3 therapy sessions, but we will do whatever is best for you to make sure you are ready to go home and safe at discharge. When you do get ready to go home, we do recommend that you go home with a care partner. The care partner should not have to lift you up or push or pull on you, but it's a good idea to have them around as you're getting in and out of the shower to help you with food and drink. So if I had to make a recommendation, most people are comfortable with having their care partner go back to work if they need to after a couple of days. And if they are there with you at night, then that is usually very manageable. As far as home medications after surgery, we are limited on the amount of pain control and pain medicines that we can prescribe for you. So usually 5 to 10 days of a narcotic are what we can prescribe. You will always get at least 1 pain medication at home prescribed for you. Some of our surgeons will give you 2 different medications. So usually we will use tramadol, which is a non-narcotic pain medicine, or oxycodone or Norco for severe pain. So we will make sure that your nurses go over with you all of your discharge medications and that you know how to take each of these. We also encourage you to use your ice, to rest, to take your non-steroidal anti-inflammatories if you can take those, and other over-the-counter medications we give you. And remember to take your Tylenol, 1,000 milligrams, which is 2 of the extra strength Tylenol with each meal. That's an easy way to remember those. And then if that is not quite enough, then you can take those other pain medicines as mentioned before. We also encourage you to take a stool softener or a laxative or have that on hand. If you do take any of these narcotics, they can cause constipation. Remember to get your aspirin, which I mentioned already, the 81 milligram or the baby aspirin. And then a sleep aid might be beneficial, such as melatonin, or some people like Tylenol PM. So remember, if you do take Tylenol PM at bedtime, you'll want to leave out one of those supper time Tylenols that was mentioned previously. Once you get home, expect to have some swelling in your legs. If you do, you want to jump in the recliner, elevate those legs, preferably your toes above your nose, use your cold therapy wraps, and do those ankle pumps. That hopefully will help with the swelling and it will go down on its own. You may have a sleep disturbance, and what that means is you're usually able to go to sleep at night, but you may wake up in the middle of the night and you can't get comfortable. So if that's the case, then listen to your body, get up with your walker, walk around, maybe walk around the house one time, do a few exercises, use your ice, something like that, and then you're able to get back in the bed and go back to sleep. So that usually only lasts a week or 2, and then you find yourself sleeping through the night. It does not mean that anything is wrong. It's actually a pretty common thing that we hear about, but do whatever you need to get comfortable. Make sure that if it's more comfortable for you to sleep in the recliner, you may do that. Or if you like to sleep in the bed on your side, you can do that as well, but make sure you do use a pillow between your knees, especially to help you observe those hip precautions if you're a hip patient, as well as keeping you more comfortable if you're a knee patient. If you want to progress your activity as tolerated, really rest more the first week and give those tissues time to heal. And make sure you're using your walker until your physical therapist tells you that you can put it aside. You may need to progress to a cane, or you might just not need anything after they tell you you can get rid of your walker. But just put your walker in a back closet. Don't get rid of it, because you can only get a walker or a bedside commode once every 5 years, according to your insurance. So don't get rid of that. Just put it in a safe place. Now, a couple of things to be concerned about. Call 911 if you have shortness of breath or chest pain. You'll want to return to a Prisma healthcare facility if possible. However, if you think you might have a blood clot or an infection, I would not rush off to the emergency room. Call either your home health provider or call us at the surgeon's office if you think you might have either of those. Symptoms of a blood clot would be swelling, pain, or redness that don't improve with elevation. And that's a picture of a left leg with a blood clot there. Signs of infection would be increasing pain, redness, a lot of drainage, like 50 to 75% of your dressing covered, or a persistent fever greater than 100.4. So if you have any of those things, we would like to know about that. Again, I would not rush off to the emergency room, because you might wait forever and then they would just ask you to come see us anyway. So call us first and we can give you further instructions. Driving. About 3 weeks before you can drive, you want to make sure you have either your surgeon or your physical therapist approval before you do drive. Depends on which side you get operated on. You want to make sure your coordination and reaction time is back to normal and you are off of your narcotic pain meds. So the first time you drive, go around the block, make sure it feels okay, and then you can drive longer distances the next time. Next, before any future medical appointments, make sure that you let either your dentist, urologist, or gastroenterologist know that you have had a total joint replacement. There's a risk of infection with any of these procedures, or visits to your dentist, for example. That would be with cleanings or any procedures that you might have. So again, make sure that they know that you've had your joint replaced, because they may need to give you an antibiotic for you to take about an hour or so before your procedure to help prevent an infection. So in most cases, those physicians or dentists are comfortable calling in that medication, but if they are not, then contact us at the surgeon's office and we will be glad to call in an antibiotic for you. And speaking of the dentist, which is the one that we think about the most, that covers any regular cleanings or any dental procedures. So you usually only go twice a year. We do recommend that you take the antibiotics for life. Our surgeons also recommend that if you have a cleaning scheduled, make sure that it's at least 2 weeks before surgery or 3 months after surgery. Now, if you have any sort of dental emergency, go ahead and get that taken care of by all means, because you don't want a possible infection in your mouth to spread to your hip or your knee. And finally, as of January of 2020, under Medicare A and B, your surgery for knee replacement is now seen as an outpatient surgery. So you can still stay overnight, even if you're an outpatient. And if there's a medical need, you may even stay 2 nights under outpatient, but there must be a medical need for you to stay an additional night. If you have a private insurance or a managed Medicare plan, then they determine if your procedure is going to be inpatient or outpatient. That also holds true for our hip patients. But if you are a hip replacement patient and you have Medicare A and B, then your surgeon determines whether or not you're going to be inpatient or outpatient based on your medical history and a list of medical comorbidities. Same-day discharge is not a problem with any of the insurances. But if you have any questions about what Medicare will cover or what you would have to pay, call 1-800-MEDICARE and they could give you specific instructions on what your charges might be if you're an outpatient. All right, thank you so much for choosing Prisma Health Patewood Hospital for your surgery. If you have any questions, all of our numbers are located on the back of your booklets, and we look forward to seeing you when you come in for surgery. Thank you so much.